So good morning to everybody. Talking about size, does size matter? We'll try to understand which are the different meanings of the size word could be applied to this minimally invasive. So we'll talk about the size in terms of approach, in terms of size of patients, and in terms of different prostheses. Let's start talking about size and centimeters of skin. Let's say we completely abandoned the full sternotomy back in 2005, moving to different or less invasive procedure. We started initially with the mini sternotomy, V-shaped second space interrupted, as Andrew showed us, and we had a good experience on it for many reasons. Most of our aortic valve replacement, isolated aortic valve replacement, were performed through a thoracotomy. So we progressively changed our mini sternotomy approach to a J-shaped third intercostal space, which allowed to perform even as an aorta or root procedures. So, but the beginning is why to do it. The very beginning was, let's say, a review which showed that minimally invasive could give some benefits in reducing mortality, ICU inward stay, ventilation time, but every surgeon almost experienced longer cross-clamping time and cardiopulmonary bypass time. So, but most of them were mini sternotomy. So we tried to build our path, and we published in 2010 this. 2011, this report of our first experience in 192 consecutive patients treated through a right anterior mini thoracotomy. Initially, there were only sutured valves, and these were the first outcomes, which were encouraging. So we decided to match the population, and we published a propensity score matched study between comparing right anterior mini thoracotomy to conventional aortic valve replacement through medium sternotomy. We collected two population propensity score matched of 138 patients each, and we observed some difference, some good results in terms of blood transfusion and ventilation times, and no big difference compared to other things, including new onset postoperative AF or hospital stay. This was the initial procedure, very old procedure if I see the equipment we used. This was back in 2005. This is second space, anterior second space. We abandoned that trocar positioning because it's no longer useful. And soft tissue retractor insertion, which is very important if you have to deal with the short skin incision. You can see over there the aorta behind the pericardium, which has to be opened and divided. And now we perform two purse-strings on the distal ascending aorta. We'll talk about anterograde perfusion and what credo about it in the afternoon. But we as well cannulate percutaneously the femoral vein under mandatory transesophageal echo control, which is very important. And this was a cannula we used to use. We don't use it anymore. It's a cannula with a blade inside, which is a retractable blade, which allows an insertion without no incision on the aorta. No incision except the cannula itself. This is the retractable signet clamp, extremely useful for this procedure. We used to put vent always through the superior pulmonary vein, And this is the cardioplegia administering. So after the heart is stopped, we move to the rest of the procedure as in the normal fashion. We can put some stitch to open the aorta, or which is a procedure we actually abandoned because, especially with sutureless valve, it's no longer needed. And all the rest is what you do every day. So we decalcify, we remove the leaflets, and we try to put the stitches. We usually use biological valve, the supraannular, in a supraannular fashion. This was Edwards Magna, which has to be obviously sutured and lowered in position in your normal way. As you can notice, it can be quite tricky to fit the prosthesis into the access. And then you tie your sutures in a normal way. Sometimes if we have a very far annulus, we could use the knot pusher, which is something I personally don't like. I always prefer my fingers to have a proper filling. And we use a single suture 400 to close the aorta. So this is basically the results in terms of cosmetic. And at the end of 2014, this was our results, which we presented at the EACTS meeting. Right mini thoracotomy for AVR in almost 600 patients. This was along the years, starting from 2004 up to the few numbers in the beginning of 2014, the proportion of AVR cases performed through right anterior mini thoracotomy. And this graphic includes even associated procedures. In isolated AVR, it reached almost 92% in 2013. As you can see, biological valves, sutureless biological valves played a very crucial role in it, and we'll talk about later. Then we compared minimally invasive aortic valve replacement in right mini thoracotomy and in mini sternotomy. We found actually some difference. The sample size was not big, but we found some difference in terms of ventilation times, ICU stay, and ward stay. These are data we presented in the 2012 ISMICS that we have published already. But what was the decision making? CT scan, if you plan a mini thoracotomy, is crucial, absolutely mandatory. So we try to understand if aorta, ascending aorta, at the level of the pulmonary bifurcation, is right-sided or centered compared to the right margin of the sternum. So the yellow line is the yellow circle is an aorta which we probably would treat in mini sternotomy. The other one, we could probably plan a mini thoracotomy for it. This is the rationale. They are suitable if the aorta is rightward compared to this right margin, and if at least half, or it's probably better, more than half of the aorta is right-sided, this, if it's not longer than approximately 10 centimeters, let's say, it's suitable for mini thoracotomy. In this case, mini sternotomy will be the procedure. These are rules which we strictly observed planning replacement for with a sutured valves. For a sutured valve, With the sutureless valves, we were able to be less strict on these rules. And let's talk about the size of the patients. And talking about size of the patient, we all know that opening a sternum or opening a thoracotomy in a very thin patient or a very big patient is completely different. And this is how, this is where CT scan can help. 3D reconstruction can show us exactly where to cut and what to find in the different spaces. We know that if we want to go anterograde with the perfusion, we'll have to go second space because we'll have to cut at this size, cannulate at this size, at this level, and clamp right under it. Going on the third probably could lead could end in a completely different approach. And in this case, if we have a very low or very high aorta or very short aorta, we could decide to cannulate peripherally. Lateral view could be useful as well. But there's another kind of patient which is very important to treat, to be considered, is the elderly patient. We published this propensity score matched study on octogenarians, and comparing full sternotomy versus right anterior minithoracotomy, we found that we observed a shorter time for extubation and shortened hospital length in right anterior minithoracotomy. And the final consideration was that probably in this quite fragile patients, often fragile patients, minithoracotomy can be safely performed with good results. And then we finally think about the prosthesis. At the beginning, our minithoracotomy were performed only with sutural valves. Then we had a small experience with Intuity and Enable, but our final choice was Perceval. Why sutureless prosthesis? Because we want to improve our results in rapid deployments, standardized techniques, and in minithoracotomy, this it really does facilitate the procedure. First papers were encouraging with proving good outcomes and hemodynamic results. And this was our initial experience. Since May 2010 to March 2013, we experienced all three sutureless or rapid deployment valves on the market. We abandoned Enable because there was not compatible with our kind of minimally invasive minithoracotomies. So we judged it not easy to reproduce, to perform. We started Perceval, which is now our prosthesis of choice, and we had a short experience with the Edward Intuity, which is an excellent prosthesis, but again, not very easy to be implanted in minithoracotomy because it's not collapsible. These were our initial observation on cross-clamping time savings, on 100% implant success, and compared to our previous paper about early outcomes in minimally invasive aortic valve replacement with sutured valves, we obtain almost 50% less in cross-clamp time. So this was our first published data on sutureless implantation of the Perceval S through right anterior minithoracotomy. At the beginning, we had 137 patients, and the only thing I want to stress is that in many cases, when we had asymptomatic coronary artery disease, which we discovered in most of the cases in preoperative tests, we decided if it was feasible with PCI to proceed with the minimal invasive aortic valve replacement and perform a second stage, let's say, hybrid revascularization afterwards. Again, this slide to show you that 10 centimeters from the wall are very important if you have to tie with your fingers the sutured valves. And the angle is very important if you want to put the stitches, especially on probably the most difficult part, the right sinus. But with sutureless valves, everything is definitely easier. So you could actually be less strict on the rules we stated. And this is the procedure with the sutureless valves. Usual second space, almost the same setting. As you can see, materials has changed. This is a completely different soft tissue retractor, which is extremely effective both for aortic and mitral valve. One thing that never changed is percutaneous venous cannulation, which is now this is Dr. Glauber clamp, which is completely detachable and removable, and this is the procedure. We give one shot usually of warm blood cardioplegia. Then we remove the prosthesis. We size the prosthesis. As you can see, we have no stitches to open the aorta. After we sized, we put the 3 nadir stitches the colleague before mentioned. And in this case, we could have decalcified a little better. And then we collapse the prosthesis. This collapsing is a procedure which takes less than 1 minute in expert hands. Once we have collapsed the prosthesis, we put the 3 suture lines, guide sutures on the 3 green marks, and then we lower the prosthesis. With the collapsed prosthesis, we still have space enough to put the valve in position in a very effective way. This is the valve after the positioning. Perfect coaptation between the 3 leaflets. We inflate the balloon, we dilate with the balloon, which is a procedure we do not use anymore, and then we use the same fashion closure as normal to close. That's it. Oh, sorry, this was probably something you'd be interested in. The echo results, which are nice. Talking about Perceval and not only mini thoracotomy, we presented this data in Milan last ACTS Congress about our 3-year single center experience on almost 400 patients. We used many surgical accesses, but more than 80% of them were right anterior mini thoracotomy. Baseline preoperative data, nothing very significant, except here that we treated mixed lesion, stenosis, even regurgitation, an off-label procedure for the prosthesis, and we did a redo procedure on the generated prosthesis in 30 patients. We could associate procedures in 89 patients. 71 of them were treated with the full sternotomy, obviously, if we had to implant bypass or to perform any other valvular procedure. In 18 of this mini thoracotomy, we associated myectomy or AF surgery. So these were early outcomes with 6 hours of assisted ventilation times, 28 patients in prolonged ventilation support. We had good results in terms of early complications. We had 3.8% of PM implant and nothing really different from our previous experience. We had 24 patients in which we had to reopen for bleeding. Most of them are related to our very first part of our experience. This was mortality, different in isolated procedures or in combined procedures, even if and the error score was higher in those patients as well. So these were the results in terms of echocardiographic follow-up data. We had 14, then 10 and 10 at 2 months and 24 months of a mean transportetic gradient, and 22 of peak, which became approximately 17. Other results, and in this Cox multivariate proportional hazards, we evaluate as independent predictor of mortality, cardiopulmonary bypass time, and prolonged postoperative mechanical ventilation support. This was the cumulative survival. And then our experience pushed again forward with the double procedure through right mini thoracotomy. And this is the actual procedure. We had here, well, this is not a good echo imagine, but we had moderate to severe mitral incompetence and a severe aortic stenosis. This is an opening through the third intercostal space. As you can see, it's very, as you can imagine, it's very, very important in this case, having to deal with both valves, the positioning of our opening. This is the normal anterograde perfusion. This is the retrograde venous cannulation. This is cardioplegia needle into the ascending aorta. Our retractable removable clamp. And as you can see, the opening, it's a couple of centimeters bigger than the isolated aortic valve replacement. We now stop the heart, and we have plenty of space to open the atrium and to expose the mitral. I'll try to skip something here because it could be okay. It was enough a ring in this case. We positioned, if I will not remember, this is Sorin Memo 3D. Normal procedure. And we suture it. Okay, after the water test, we concluded that the ring was enough. Then we closed the right atrium, and always through the same opening, we opened the aorta. And after having excised the leaflets, we implanted, after measurements, another Percival. Here it is. This is the positioning. As you can see, the collapsed valves allows you to check the level of your positioning simply by moving the annulus with your forceps. And after having released it, this is the result. We always check for the leaflet coaptation, and This is the first time. This is the first thing you have to do. Then we check if any remnants of the annulus is left below or over the prosthesis ring, which actually is good in this case. Then we balloon, and all the rest, you know it very well. This is the final incision. And the good results in terms of echographic data. This was our very first report of 69 patients treated with this procedure in a sutureless AVR and mitral procedure. These were the pre-op population. We performed the AVR and mitral valve replacement in 27 patients, mitral valve repair in 35, and both repairs in only 7 patients. We were able to combine tricuspid valvuloplasty, AF surgery, or myectomy as well. These were the results in terms of times of cardiopulmonary bypass time and cross-clamping when we performed the AVR with sutureless, an S is missing, and sutured valves, as you can see, quite different, and with good results of outcomes, 0 mortality, only 2 strokes, and 15% of blood transfusion actually. So for any kind of patients, you are scheduling your AVR. There is a way to assess the best minimal invasive for them. Most of them can be treated by mini thoracotomy, and definitely sutureless valves are a great help to optimize the results. Thank you very much.
Any questions on the floor? David?
Everybody sleeps.
So, as you know, Andrew, I'm a bit of a skeptic about this, and
yeah.
I really think, and it's perhaps the questions to both of you, but it's really minimal access, not minimally invasive. I worry here that, thinking of the presentations this morning, earlier as well, that certainly the sutureless valve lends itself to the minimal access. I can see that. Yeah. But one of the arguments for the sutureless valve is that it saves a bit of bypass time and a bit of cross-clamp time. And that might or may not be important for the patient. And yet, in this approach, it seems the bypass times and cross-clamp times are longer. We've added a CT scan with a not tiny dose of radiation. The CT scan has a radiation dose and an expense, and added a femoral venous cannula, which is pretty safe these days, but not completely benign. So I just worry that you're adding quite a few extra steps for the patient. And it may be good for the surgeon, and I'm sure you're both good surgeons and you enjoy doing it and your results are overall good, but is this translatable to everyone? And is this an operation more for the surgeon than the patient? And my real question is, if the 2 randomized studies going on in the UK fail to show any benefit, will you carry on doing mini AVR, as you call it, or not?
Well, I think the randomized trial will probably, well, if it doesn't fail, if it fails to prove advantage in terms of blood transfusion, well, I think it will be considered at least the same. So I think that probably the cosmetic benefits or the better results in terms of patient satisfaction could be in favor to the minimal invasive. I think so, just because we're dealing just with blood transfusion data. If we had a difference in terms of mortality, comorbidities, yeah, well, that would be
that would
great,
be easy. That would make it easy. Yeah.
A big problem, but I don't think so. I think that what we observed is good advantages, but especially for a certain kind of patient. I mean, a 50 years old man can be operated in both in sternotomy or mini thoracotomy or mini sternotomy with excellent results for all of them. So I don't think the real difference you can appreciate in those kind of patients. But if you have to deal with that gray area between the operable patients and TAVI patients, which in places like Germany has gone completely to TAVI. So if you have to deal with the elderly patient, fragile patient, so having a small approach with a rapid deployment valve, well, for many of these patients, I think could be help, could work. We actually published some data about our propensity score matched population between TAVI and sutureless valve through right anterior mini thoracotomy. We showed the same results, but with a significant difference between postoperative perivalvular leak in favor of the surgical procedure and a different mortality in terms of time, but probably because the TAVI patients were very, very, even if propensity score matched the study, probably they were more complicated. So I think that for those gray area, we had the same results and probably a safer and a more definitive solution with the surgical.
I mean, for me, there's two. The randomised data out there on mini AVL doesn't really support doing it at the moment. The two UK trials, hopefully we'll get data from in the next year or two. Both have got fairly large cohorts of patients, so it should give us an answer. And there's three possible answers. It'll either be better, worse, or the same. If it's worse, then it'll kill it off in the UK probably. Well, there'll still be some enthusiasts possibly. If it's the same or better, then it'll come down to patient choice. And if it's better, which time will tell whether it's remarkably how well patients do if a consultant does the operation to skin with a full sternotomy. But if the results are exactly the same and the patients come to you wanting a mini, why wouldn't you do it a mini? It's cosmetically better, it probably hurts a little bit less. You're really going to struggle to show benefits like mortality and stroke rates.
Well, the difference was the big difference in terms of cross clamping and cardiopulmonary bypass time was with sutured valves. We had definitely bigger, longer times. So that's why we had to select patients. But things made a lot better with sutureless ones. So I don't know, probably. Okay.
The good thing is we're learning from the cardiologists. So the trials are powered for non-inferiority, which means you can carry on doing what you want. It's quite clever.
I suspect those who like, yes, if we show there's no benefit, those who like big holes will do big holes, and those who like little holes will do little holes. And yes, exactly.
I'm surprised, though, you haven't mentioned the elderly and poor respiratory function, which I thought were the two groups where you're most likely to see the clear benefit.
Doing a trial purely on elderly patients would be quite difficult to. We've decided to go for all comers. Respiratory function is something we were very keen to try and see if we could show a benefit, and we're trying to look at sort of physio measures and getting them to do peak flows and FEVs and things. But whether we didn't have any raw data on which to base that. So it'll be something which we're measuring, but whether it'll come out, it'd be great if it does. I'm aware that time is moving on, so unless there's one last burning question.
Have you got a handle on how much extra business this brings you in terms of how many patients are referred that wouldn't normally be referred to you just because you offer the service?
The number of AVRs in our hospital has gone up. I think that's a function of two. I think the mini program has put up the numbers, but probably the biggest thing that's put up is having surgeons on the TAVI MDT. We get more. You drag lots of patients who would have previously been turned down for anything, get dragged out of the MDT and rescued, and have severe aortic stenosis in an 80-year-old, and some cardiologists have said they're not fit for surgery. There's no reason why an 80-year-old shouldn't have an AVR. So you land up. We do far more AVRs since TAVI started in our hospital than we did before. Okay, thank you very much. Sure. Thank you.